And the last modification, the last major big modification change was the last year with a new law. This new law have a lot of new issues, new features for our health system, but the main for me is this, right now we consider the health as a human being. So, and right now, probably the best word is health as a human right, more than human being, sorry, I think it's not clear. Right now, health in Colombia is considered a human right. What does it mean? It means that every Colombian has the right to have health insurance and health attention for their problems. This is a big statement for our country. This is the general scheme, how I can present you the general system of social security. Is divided in three main systems. The first one is the blue, the general system of health. The second was part of the same law in 1993, the retirement or pension system, and the occupational health, the labor health. The general system of health is divided into main lines. The first one is to the working people, with the working people who work, that give money to the system to finance the system. And the non-working people or unemployed people who goes to the subsidized system. The subsidized system is paid by several funds, several sources of money. I'm going to explain a little bit more in a few minutes. With the general system of retirement or pension, how we call that, is based on individual savings. So people during their life working are giving money to an institution who save the money. It's kind of a bank, something like a bank, and gives you back when you have the age for the retirement. Right now we have the 73 years for men and 60.
57 for women.
57 for women and 63 for men. Thank you, Laura. And they have back an average payment for giving them the money every month till the day they die. And there's another big system for general occupational health. The people have insurance companies who give them some kind of protection and services when they have an accident during the work or inside the company they work in. I'm going to focus right here because we don't have so long time to talk about that. Yes, the general system of health, we have two main plans. They are called the obligatory health plan for the contributory system and the obligatory health plan for the subsidized system. People needs to have to give money to insurance companies. So we have insurance companies. We call them EPS. I'm going to say that in Spanish, Empresas Promotoras de Salud, Health Promoters Enterprises, kind of this. Those insurance companies collect the money every month. It's a part of your salary. If you are working, you have to give the 4% of your salary, and your employer has to give the 8.5% of your salary. So this 12.5% is the money that covers your health attention, and also your family health attention. So this is important for us because on our first system on 75s, on the first national health system, they don't have cover. We didn't have cover, for families, only for the worker, only for the person who works. From the 93, we have covered our families too. So my daughter, my wife, my family, my close family, they have coverage, full coverage, daughters and sons till 23 years old. This is with the money I give from my salary, from my month's salary. So these insurance companies, Health Promoter Enterprises, I have the name here, the same name here. They collect the money and they guarantee you are going to be attended at the clinics, hospitals, and in the professional health professionals. So they do that through contracts. They make contracts with hospitals, with clinics, and you can go there when you have an emergency or when you are sick. Just call, ask for an appointment, and go have your attention, your full attention. Well, and the other thing here is important, and focus here in the blue, is the collective interventions plan. This is our public health plan. We have a public health plan for everybody in Colombia. No matter if you work or if you don't work, if you're not working, you have the right to have the collective interventions plans with actions in public health. The collective interventions plan is given by the municipalities to local governments and local hospitals, public hospitals, by the way. In the states, what we call departments, and towns, big or small towns, doesn't matter. Well, this collective interventions plan, I'm going to focus a few minutes here, is given by, as I told you, public health hospitals. These public health hospitals are built in communities in everywhere. Like for us in Bogota, 8 million people, we have right now we have 22 public hospitals across the city in every neighborhood, almost every neighborhood, with 260 more or less points where people can go and have attention. Primary healthcare and second level, I mean the specialized and high specialized, third level. We call third or fourth level of attention in Colombia. Collective interventions plans are given by these hospitals specialized in the primary health care. So, let me try to explain this. In this structure, the primary health care hospitals, called the first level hospitals, they are giving the people few things like this and this one, related with the needs on health promotion, health education, and prevention. So, by law, this is a regulation, wide regulation for Colombia, and we have community-based rehabilitation, vector transmitted diseases, social and collective networking, advising, health information, health education, communication, what you see here. And also vaccination, medicines to special problems with major interest in public health, like tuberculosis, leprosy, malaria, leishmaniasis, Chagas, and others. We provide condoms, syringes for drug users. It's part of our law because we consider, of course, it's a major problem, the drug users, but part of the problem is a public health problem, of course. This collective interventions plans is based on health needs, outcomes, and goals. Is made by two main lines: health promotion and health and risk management. What we do in Colombia in public health, we have a master in public health in Colombia in our university. We're a program with 5 years old, only 5 years, almost 6 years by now. Is to educate our students in what should we do, what should they do in Colombian municipalities, like these first level hospitals, and other kind of institutions, like in the national level, the health ministry, the Health National Institute, and kind of this. We're very focused on social determinants of health, what we try to understand better in our classes. Laura is there and she knows that. But right now we are thinking how can we deal with the new problems of our system. We have this story of 23 years with the new system, no, not so new. And we have these new challenges to improve health quality. So what I'm going to do now is focus a few minutes of my presentation on a recent report published by the OECD organization. It's an organization of economics and cooperation development. It's a worldwide organization. I don't know if somebody of you have information of the OECD. The United States is part of the OECD, European countries and some other Latin American. And they made this report in December 2015, just a few months ago. And they gave us recommendations, and I think it's a very good report talking about the challenges and the facts, the achievements of our health system. This is the web page of the OECD, in case you want to consult that. They have a lot of information, more focused on health economics, but they evaluate the public health systems in several countries. For us, it's a very good source of information. And it's independent. I like that, because when you look yourself, probably you're not so good giving the bad news. Well, this is the OECD webpage. Well, what they found, they call facts, and I have the same word here, is this kind of facts. You can see this, and it's very good for us. Infant mortality has fallen from 40 to 12.8. And this is a measure of 2013, so it's a very good data from our health system. Right now, and this is 2015, 98% of our population has the possibility to access the health system, to have healthcare in Colombia. This is very good for us. Of course, it's very good. It's a major achievement. Of course, we have new challenges there, because this 98% sounds very good, but when you go to the reality and every day, probably you have to wait 3 or 4 months for an appointment with a doctor. We have to wait for the medications. We have kind of the same problems everywhere. Well, health insurance right now, and the coverage increased most rapidly among the poorest 20% of the population. From 4% in 93, you can see this, it was very bad, to almost 90% right now. So this is a major achievement again. You can see this, we can be happy about this, but again, we need to work harder. And in rural areas, this is, I'm going to stop here right just for a moment. Colombia has probably 12 major cities. No more than that, but we have more than 1,000 small towns all around the country. And those small towns are very depressed because they don't have the main services like water, like energy sometimes. So 80% of our population in Colombia, 80% of 48 million people, lives in probably 12 or 15 major cities. The other 20% are very widespread in a very big country with the very small populations. So this is a major problem for us because we don't have very good infrastructure. We don't have good roads. We don't have good communication lines. When you have to go, and John has experience there in Chocó and with their team, when you go there, you find another country. It's different Colombia in Bogotá or Medellin when you go to Quito or small towns, or when you go to the forest. It's very different. So we need to close that gap. We have a very wide gap between the main cities like Bogotá, like Medellin, like Cali, Cartagena, 10 or 12, and the other 1,000, 4,000, something more. So close this gap is a major challenge for Colombia, and not only in health, in economy, in employment, in justice, in president of our state. Probably you know Colombia is been struggling with an internal war. We call it conflict. Anyway, we're trying to close that, to end that. our government is very committed with. Nobody is agree with that process, but anyway, our government is committed with peace agreement, and I talk by myself. I am very committed with that too. I like the idea. I hope this is going to be true very soon, because all my life I have been living with the war in Colombia. So we need to stop that. And when you stop a war, you need more state presence. You need more state institutional presence, presence on money, budget, authority in the countries, in small countries and municipalities. Second is important for us. The out-of-pocket expenditure paid by patients is only 40%. And this is interesting because the OECD report, where I took this information, is recommending to increase this level. And I'm not agree. We have to put the out-of-pocket payments low, very low, very small, because otherwise people have a barrier to access the health system. So even for a lot of people, this is so high, they can pay this. So this is part of our permanent talking about the system. This is one of the lowest proportions in Latin America. You see, we are below the average, around 20%. Unmet healthcare needs and waiting time for medical appointments have been reduced. Anyway, they are still long. They are more than 3 months for specialized services, like oncology. This is a major problem for us. And we need to incorporate more technologies to update our technologies. Some places in Colombia have very old technologies. They don't have the best for the people's attention. As I said recently, 98% of total population covered. Again, in the data, in the sources. And the subsidized regime, where people don't have to pay from the pocket, is almost 50% of our population, over 23 million people. This is a very good achievement, very important for us. Well, challenges? A lot of challenges, of course. And this is directly from the report. The focus now needs to be on improving quality, efficiency, and sustainability. We have corruption in Colombia, everywhere, but we have high levels of corruption with public health insurance money. Local governments are not so good or honest managing the money for healthcare. The insurers in Colombia have not yet developed effective and efficient purchases of healthcare services. So this is based on contracts, and the contracts are not so good for the doctors sometimes. So when the people try to have new insurance or try to go to a clinic, for example, they have barriers for access because they need to confirm if you are in the database, if you are in the insurance company. If the insurance company gives us the authorization to help you, to attend you, it's a big change of steps and procedures. It's not easy. It's not so easy. So in the paper, it looks very good to have, again, the 98%. But in the real life, we have a lot of issues to have the best clinical attention. Payments to doctors, clinics, and hospitals should increasingly reward healthcare quality. So this is about what contracts have. Again, the contracts used to have, you give you money for the amount of population. So you have 5,000 people. I'm going to pay you X or Y for every person, not for quality, not for effective attention. So this is not so good because they are given incentives to bad attention or to not efficient or effective attention. So not focus on volumes, but focus on quality of care, quality of the care, of the health care. And again, the country needs to work towards stronger performance and accountability management for health insurers. So this group of health insurers, they are becoming bigger and bigger. They are absorbing the smallest kind of monopoly practice. And they have not so good, not so sane practices. The money is there. So they are growing, they are having very good profit, but sometimes people is not happy. So they are not giving the best care to the people, but they are making money.
Sorry, I must have missed it. The previous slide when you said out of pocket is 14% and that's lower than the average 19, did you say that's good or that should be higher or that should be lower?
Well, okay, good. For us it's 14, and this is the average for Latin America. So we are below the average. Okay. For me, it's good 14, but the OECD recommends to increase that. So they say we need more and different sources of money for the system, and they suggest to increase this. I'm not agree, because we need different sources, not the people pocket money. So that's my comment. Here, okay. Better management practices. So we need to keep working on better management practices, improving the skills of our managers in public health, in public hospitals, and private hospitals too, because we are still trying and struggling with low capabilities, especially, again, outside the main cities. In the small countries, in the small cities, small towns, we need more and more from, like us, universities, working with people, giving more information, giving more education to the people to improve their skills. This is a major problem. We don't have a strong and very good and reliable information system. Our Ministry of Health, placed in Bogota again, is working from the last probably 4 or 5 years, building a new health information system. It's called CISPRO. It's trying to integrate different resources and sources of information from databases, from the epidemiology, statistics, mortality, morbidity, any kind of thing. All kind of different sources, but still it's not easy. And probably it's part of what we've been talking about, this not so good, not so hard structures in the small cities, small towns. The development of more sophisticated information system, that is the goal of our Ministry of Health, could be better for even to participate in these kind of reports. I think I have a few more. More challenges. During this year, the first semester, the Ministry of Health built the new policy for integrated health attention and a new model for healthcare provision for the whole country. So based on our more recent law, the 2015 law I showed you in the first slides, they are proposing to the insurance companies in Colombia the new model to attend people, to improve the attention, the quality of attention, the opportunity to. This is a new challenge for us, is consolidate this policy and model. Changes in the relationship between healthcare providers, clinics, hospitals and professionals, and insurance companies, because they are based, again, in contracts, and the contracts are not the best way to have the relationship, because they are based on money, not in health. Contracts are issued, are paper for talk about money, not for talking about health. So they are not concerned about the health outcomes but they are very concerned and they invest a lot of money and a lot of time watching for the money, the profit. And what I told you recently is, for me and for us, we are facing a new age. We are trying to make new steps with the peace agreement. So hopefully Colombia is facing new changes, new age, without the war, without the internal conflict. Probably is what we hope and what we want and what we need and what we wish is to have a new country. Yeah, and a new country without a war. This could be the best for everyone. But again, this is a challenge because we need to guarantee healthcare and well-being for every person in the country. This is the challenge. When you have the peace, we don't have excuses to don't give good care to the people, to don't respect the people, to don't give them what they need to be happy. We have few of them. Real access, probably I told you, to care services programs, because if you can have 98% of your people in the database, they can come to the hospital, but they need to wait there in emergency rooms like 6 hours or 8 hours, sometimes, or maybe more, I have to say that, to have the services. So we have real access programs. Very wide open gap of information asymmetry. The information is placed on the insurance companies. They know everything. The doctors just know a few, and the patients is out of the information circuit. This is very bad. So when you have more information than others, you have more power. The specialized levels. This is a difference between us and you in the United States. Probably you have more specialized level than primary health care level. We have more primary health care and less specialized levels. I mean with the doctors, specialized doctors and services. We are more focused on general practitioners, medical schools and dentists and nurses, especially in small towns. When somebody lives in a very small town under 10,000 people, and they have a diagnosis of leukemia, for example, they need to go. They need to go to a main city to have the attention. Otherwise, they can just die there. It's sad. High levels of intermediation gives money and to the wrong persons. Sometimes accountability is still weak, and we need more transparency levels. High levels of powers in the insurance companies, as I told you, and we have still poor levels of surveillance and control, and some not so high, but some institutional weakness in our central and decentralized level. Well, this system, our health system is based on a model called managed competition. I don't know if you're familiar with this. It's from Alan Entowin here in the United States. And the other model is based, the other base is the model of the structure pluralism from Julio Frank. You know Julio Frank, Harvard School of Public Health, and Juan Luis Londoño, one of our former health ministers. And the base of the idea is the insurance throughout private agents that work as administrators of the money. Probably this is the overview of our system. I think I have a few minutes more. I'm going to give you 3 or 4 more slides about what we are doing at the Bosque University. Bosque University is a 39 years old university, private school. It was born in the 70s, late 70s, as a medical school. Right now it's a university with engineering, arts, and music, and laws. But we are still focused on medical school, and dentists, nurse. And from the last 5 years, very focused, growing on postgraduate offer on public health. So we have a Master in Public Health. Laura is one of our students, Master in Public Health, second year. I'm the director of the Master in Public Health. And we are building a new PhD program on public health in Bogota. We hope to open that for the first cohort the next year. And this is important too, because in Colombia we only have, for 48 million people, we only have 3 public health PhD programs in the whole country. And there's one in Bogota, in the National University, public university, and 2 in Medellin, and in another public university, Universidad, Antioquia University, and a private school, CES. This is going to be the 4th PhD program in public health in Colombia. So it's a great opportunity for, again, build capabilities, increase skills for health, public health especially. Well, we have, as I told you, all the new problems. We have a double burden of disease. We have communicable diseases and non-communicable diseases at the same time. We used to talk about with teachers, with faculty, about if we have or we don't have the epidemiological transition. And we are all the time saying, yes, no, maybe a little bit. We don't. We have to mix profiles. We have the communicable diseases and non-communicable diseases at the same time. Because we're experimenting, we're having complex transitions, socioeconomic inequalities and poverty mixed. And as I told you at the first slides, a very wide gap between rich and poor. Negligence of public health national planning documents and the consolidation of information system I told you recently. And still in Colombia, we have the supremacy of a model that's emphasized by medical individual risk factors more than community risk factors, more than community life expectancies, life features. Still limitations, leadership, knowledge, translation for addressing problems, and scarce opportunity for doctoral training in public health, as I told you recently. Only 3 programs. And this is about our university, Bosque University. We have strong academic tradition in health and quality of life, biopsychosocial approach, and bioethics. We have a PhD on bioethics in the university. We are growing in investment, research, and orientation to our development of graduate programs. And we have, as you here at Detroit, national and international partners growing on this interest in Bosque University. This is the scheme where I can synthesize the expectations of our new program on the new program in public health, doctoral program. Is based on social projection. We need to work more with communities close to our cities, close to our main cities. Okay, deal with academic issues, organizational issues, but based and focus on research and innovation. This is the first part of our new project for a PhD program. We build this program, this PhD in public health, with 3 areas of concentration. The first one is policy and health, where I'm the I'm the leader of this area of concentration: environmental health and health education. With these 3 lines, we build the program, the new PhD program, public health. We have the program based on research and application, applied research. A lot of, and we're trying to build the program again, facing the challenge for future accreditation here in the United States. We have a very good relationship with University of Texas School of Public Health. They are our partner in this process. I've been there for long 2 times, and they are our close partners in this new program. have more minutes. Well, this is more the detail how it works in a 4 years program, a PhD program. I'm not going to stop there. Milestones of the program, and yeah, this is where we're creating a new institute for public health in the university. This new institute is going to congregate and have the work with a master of epidemiology. We have a master in epidemiology, master in public health, and master in bioinformatics. We are creating this new program, master in bioinformatics. This is the first program in Colombia in bioinformatics and informatics in public health. Focus on that. And other programs, and in the new doctoral program here. With international lives and external lives, like the Ministry of Health, public health institutions, public health hospitals, municipalities, and all kind of partners. Well, I think it's what I have to show you. This is the last slide of my presentation, and thank you so much. We have time for more questions.
Thank you.